Lisa Franzi is the clinical nurse specialist in the Stroke Prevention Clinic at Hamilton Health Sciences. She has worked in the field of tobacco cessation since 2006. And with that, I'll turn it over to Lisa.
Thank you, Tina. Welcome everyone to today's session, Shifting Your Mindset, the Truth About Tobacco and the Power of Brief Intervention. Trying to get to the next slide, just hang in there with me.
You might have to click on the screen first.
Okay.
And then get it active.
Perfect. Thank you, Tina. So objectives for today as follows. Those were sent in the email, so I'll just have you just look at those quickly. Okay. So I want to start by having you imagine if an airplane manufacturer sold airplanes that routinely fell out of the sky and killed 46,000 people per year. Or maybe a cosmetics company that manufactured cancer-causing face creams with a similarly chilling death toll. Surely the government would take steps to protect the public, right? That would be a normal response. And as the public, we would also be up in arms about this as well. Yet 46,000 Canadians die from smoking every year. And I want you to think about, do we have the same response to this death toll? Does the government have the same response to this death toll? We know that tobacco kills 50% of its users. And yet, again, look at how we view tobacco. It's the leading cause of preventable death and disease, kills 1 in 5 Canadians. And in the stroke population, it also results in a significant disability for our patients. When we look at the causes of death in Ontario, you can see that the major causes here, cancer, heart disease, stroke. When we start to tease out the underlying causes of death, you can see here that tobacco is responsible for approximately 20% of deaths. So again, significant risk factor. And then understanding the driving force behind the uptake of tobacco is key, and governments in many developed countries have done some really great work in reducing smoking rates. But how does this prevention work impact future deaths from tobacco? So what is the impact if we only focus on prevention? And so preventing would be things like bans on advertising and promotion, which we are doing a pretty good job at here in Canada, increasing taxes on tobacco products, disseminating health information, counter advertising. So you can see here, if we focus solely on preventing the uptake of tobacco use, there's a very small decrease in future deaths related to tobacco use. And this is because there's still a large proportion of individuals out there who are still smoking. And we can't ban a product that millions of people are addicted to. There's a lot of ethical implications there. But you can see here, if we focus on prevention, but also treatment, we can see a significant reduction in future deaths from tobacco use. The power of smoking cessation is huge. And this is why it's so important for us to address the issue of current tobacco use with our patients and ensure that these folks receive comprehensive support to quit smoking or reduce their tobacco use. When it comes to the stroke population, the Quality of Stroke Care Audit in Canada found that among Canadians who experienced a stroke in 08-09, 41% were current smokers. And the Interstroke study reported that the significant impact of smoking on stroke was second only to hypertension. There is some good news here though. After 5 to 15 years of quitting smoking, the risk of stroke is reduced to that of someone who has never smoked before. So there's definitely some positive news here. And I think it's important to discuss, especially right now with the climate of fiscal restraint, I think it's important to discuss the burden of tobacco use on the healthcare system. There's definitely a significant financial impact on the entire system. Tobacco-related disease accounts for at least 500,000 hospital days each year in Ontario alone. Tobacco-related diseases cost the Ontario economy at least $1.7 billion in healthcare costs annually, and they result in more than $2.6 billion in productivity loss. Yes, tobacco is taxed, and this has been shown to be a powerful intervention to prevent the uptake of smoking, especially for youth who are very price sensitive. However, the revenue from taxation is really just a drop in the bucket compared to the healthcare costs associated with tobacco use. So what does prevalence look like? You'll notice here rates of smoking have gone down. We used to be around 20%. So Canada, 11.6. Ontario, we're at 12.8%. Hamilton, we're definitely higher than the provincial and national average at 15.4%. Interesting is that the mean age at which ever smokers, age 25 and older, had their first cigarette was the age of 16, around 16 years old. And we'll talk a little bit more about that later, but this really speaks to the tobacco industry at work, using their savvy marketing tactics to hook young people onto nicotine. They're really experts at navigating loopholes to target young adults, and we'll get into this shortly. So we're going to have our first check-in. So Tina is going to pop up that that poll. So the first.
Sorry, I just want to highlight that there are two polls. So you'll need to click on the second page of the poll.
So I'll go ahead and read the first question if that's okay, Tina.
Yes.
The leading cause of preventable death and disease in Canada is it poor diet? Is it tobacco use? Is it alcohol use? Or is it traffic accidents?
And you can go ahead and read the second question as well, Lisa, as people are responding.
Okay, so the next question, after how many years of quitting is the risk of stroke reduced to that of someone who has never smoked before? Is it 5 to 15 years, 10 to 25 years, 25 to 35 years, or 35 to 50 years?
Okay. So I'll close the poll now. For the first one, 100% of people chose tobacco use. And for the second one, we have 80% chose 5 to 15 years. And then a couple chose 10 to 25, and 35 to 50.
Yeah, thanks, Tina. So absolutely leading cause of preventable death and disease is tobacco use. And after 5 to 15 years of quitting smoking, the risk of stroke is reduced to that of someone who has never smoked before. And I should also mention that you're going to see benefits from day one. As soon as people start smoking, they'll start to see immediate benefits. Thanks, Tina. All right, so this is where I really get into the truth about tobacco. I think this is really important when we're counseling patients and trying to understand why people start smoking. It's really important to understand the role of the tobacco industry, also known as big tobacco. You know, I often hear from healthcare providers that patients choose to smoke. It's their problem. They're doing this to themselves, and it's not my place to intervene. But we really need to start placing blame where blame is due, and that is not on the individual, but rather on the tobacco industry, also known as big tobacco. And again, this lays the foundation for how we approach patients who use tobacco. The tobacco industry has long denied any previous knowledge of the addictive nature and harmful effects of tobacco products. You might remember back in the 90s, millions of tobacco industry documents were made available to the public viewing as part of the litigation process in the US. And these documents, along with ongoing analysis of the industry's actions, have exposed decades of misinformation and deceit to improve corporate profits at the expense of human lives. Big tobacco has deceived us. They've deceived policymakers about the harms of tobacco. They've manipulated science. They've used third parties to promote their agenda, targeted vulnerable populations, which they continue to do. And they've interfered with regulatory and public policy processes. Even worse, in an attempt to promote a positive image, they legitimize their activities and products by participating in corporate social responsibility programs, supporting a wide range of causes, programs, organizations, including hospitals. You know, if you start to take a deep dive, you'll start to discover that even a lot of the newer products out there, such as Zonic, which are nicotine pouches, very, very high in nicotine, they're actually made by, you know, the tobacco industry. Zonic's made by British American Tobacco. And this is the case with a lot of vaping products as well. So speaking of vaping products, you can see here like cigarette manufacturers, they funded research papers questioning the risks of youth vaping. They've been cited as evidence in government consultation responses by tobacco-funded campaign groups. British doctors have attended pro-vaping smoking cessation training sessions. They're taking millions in funding from Philip Morris. Tobacco giant BAT helped run a grassroots campaign that presented itself as the voice of ordinary vapers, which sought to influence government policy in apparent breach of global rules on tobacco lobbying. It's quite fascinating. You know, it's important that we understand this to understand why patients are actually, you know, taking up smoking and continuing to smoke. And the challenge with the tobacco industry is that it's always steps ahead. You know, we're sitting here right now talking about the health impacts of tobacco use, how we can help our patients quit smoking. And at the same time, there's tobacco industry staff sitting around a table plotting their next move, how they can get young people hooked on tobacco products. And the tobacco industry has developed the most well-engineered delivery system for nicotine, and that's the cigarette. They're the most sophisticated mode of delivery of nicotine, which explains why cigarettes are so highly addictive. If we compare cigarettes to nicotine replacement therapy, for instance, or we also call it NRT, NRT has a really less than ideal mode of delivery for nicotine, and it reaches the brain at a much slower pace. And, you know, therefore it doesn't really perpetuate that addiction because there's no reward involved. Very effective to help people quit smoking, but definitely does not have the same addictive potential as cigarettes do. So we know nicotine is the safe chemical in tobacco, totally safe, but it's what keeps people hooked, responsible for the addiction. It's the 4,000 other chemicals that do all of the harm, right? Cause cancer, heart disease, stroke, and so on. And this is a really important point to talk to patients about, especially when you're trying to encourage them to use nicotine replacement therapy. Nicotine is safe. It's all those other chemicals they're getting in tobacco that result in, as I said, stroke, cancer, heart disease, and so on. Many patients will come to us and say, well, you know, I'm using a light cigarette. This may be sort of a risk reduction strategy. Again, another tobacco industry tactic. The label on the side of the cigarette packages can be very misleading. The values it gives for tar, nicotine, carbon monoxide are much lower than those inhaled by a real smoker. Right? So for more than a few decades, the cigarette manufacturers have been using smoking machines to test the levels of these poisonous compounds. Meanwhile, they deliberately altered their cigarettes to give artificially low readings. So, you know, there's little holes on the end of that cigarette. As soon as the individual puts that cigarette into their mouth, they block those holes. They're getting the same amount of chemicals as they would from a regular cigarette. So again, another tobacco industry tactic. Again, continuing the different types of tobacco that are out there that you might see, chewing tobacco is very common in certain pockets of the province. I don't see a lot of it here in Hamilton, but certainly for those in different areas of Ontario, you may see a lot of patients using chew tobacco, also called spit tobacco. It's a mixture of tobacco, nicotine, sugar, salt. It has flavoring agents, thousands of chemicals, 28 of which are cancer causing. Interestingly, it also contains abrasives that cut the inner lining of the cheek, the gum, so the noxious mixture can be absorbed in the bloodstream more quickly. So, like, again, very savvy engineering from the tobacco industry. Chewing tobacco has a much higher dose of nicotine, 4 times higher than cigarettes. It is definitely not a safe alternative to cigarettes. We would never promote this as a harm reduction strategy. And we know these individuals are at very high risk of developing a number of health problems, such as mouth and throat cancer. You may also see some folks using the water pipe, also called a hookah or shisha. Many of us are familiar with this. It's a moist mixture of tobacco and other substances. Often it's flavored, you know, fruit candy. Interestingly, these hookah sessions can be equivalent to smoking up to 100 cigarettes. So again, really important to make sure that we're asking our patients what type of tobacco they're using. And if they are using these products, it's important for us to intervene. All right, this is a pretty popular topic right now, electronic cigarettes, also called vaping. You know, the evidence is clear. If you don't smoke, you should not start to vape due to the potential for nicotine addiction and, of course, exposure to other potentially harmful chemicals. Many of these products deliver a phenomenal amount of nicotine, very, very, very high levels of nicotine. Is it less harmful than smoking? We definitely think it is less harmful. Some people may be using electronic cigarettes or vapes to help them quit smoking. If they do that, you know, if it's working for them, I would support them in that. And then the idea eventually is to get off of the e-cigarette or vape. But it's not, again, not the silver bullet for smoking cessation. In the Canadian context, vapes with nicotine were legalized back in 2018. But at the outset, these products were not regulated in any meaningful way. That's and also I want to mention, we know that, you know, half of vape users in Canada are youth or young adults. And that's because these products are very aggressively marketed, right, by the tobacco industry using social media techniques, sinister messaging. There's also emerging evidence to show that vaping can be a gateway to tobacco use and cannabis use. So again, the tobacco industry is at work here. Product advertising is rampant. Young people are being enticed with over thousands of attractive flavors. It's not hard to get hooked on something that tastes like your favorite candy, right? But we know that there are dangers to e-cigarettes and vaping, and it's going to be probably 20 to 30 years, maybe perhaps before we fully understand the implications of vaping. There's certainly a lot of short and long-term health effects. You can see here increased heart rate, arterial stiffness, oxidation of LDL, and so on. So these products definitely are associated with a number of short and long-term health effects. It's also important for us to address exposure to secondhand smoke. And this is smoke that's exhaled by the smoker or smoke that drifts off from the end of a cigarette. These secondhand smoke releases 4,000 chemicals, but in a much greater quantity. Secondhand smoke contains twice the amount of tar, 5 times the amount of carbon monoxide, and it's linked to more than 1,000 deaths per year. And this is why it's really important that we ask our patients, are you being exposed to secondhand smoke? And then providing that advice. Many of you might remember Heather Crow, who was a Canadian waitress who became the public face of Canada's anti-smoking campaign. She was diagnosed with lung cancer back in 2002. She never smoked a day in her life. And it was believed that her cancer was the result of regularly breathing in secondhand smoke at her workplace. She worked at Moe's New Park restaurant for over 40 years. And in 2002, she submitted a successful claim related to secondhand smoke exposure in the workplace. So, you know, again, it's really, really important that we understand the impact of secondhand smoke is real. And it's important that we have that conversation with our patients and their family members to ensure they're not being exposed to secondhand smoke. All right, so our next check-in.
Okay, I've launched the polls and there are 3 this time.
Great, thanks, Tina. So the first question is, the addictive chemical in tobacco is it tar, ammonia, nicotine, or benzene? Okay, and the next question, is it true or false? Light cigarettes are a healthier alternative to regular cigarettes, true or false? And the last question, the amount of nicotine delivered in vaping products is considered low, true or false?
Okay, Lisa, I see that most people have responded. So I'll close the poll. For the first one, 100% of people chose nicotine.
Yep, which is correct. That's great.
And 94% chose false for light cigarettes being a healthier alternative.
And that's correct, right? So light cigarettes are just as harmful as regular cigarettes.
Okay. And then for the third question, 83% chose false, that the amount of nicotine delivered in vaping products is considered low.
Yeah, and the answer is false. So the amount of nicotine delivered in vaping products is typically very, very high, which is really, again, the tobacco industry wanting to get people hooked onto vaping products. Again, they back a lot of these vaping products, and it also is a gateway to tobacco use. Great. All right, so now we're going to dip into the addiction. So why do people continue to smoke? We know that tobacco use is a complex and addiction. It's driven by multiple components: physical addiction, psychological addiction, and social factors. And I have to put this out there. This was a statement, I believe it was Dr. Pipe of the Ottawa Heart Institute, who used to always mention, you know, picking your nose is a habit. Smoking is an addiction. And it's really important to understand that this is an addiction. It's not a choice. It's not a habit. Nicotine is one of the most highly addictive substances known. When inhaled through a cigarette, it reaches the brain within 7 to 10 seconds. It delivers that nicotine hit that makes smoking so addictive. And then it quickly clears from the brain, and there's that need for continuous redosing. It really is one of the hardest substance use dependencies to break. I'm going to now have Tina pull up a short video that shows the mechanism of action of nicotine.
When inhaled, cigarette smoke travels through the airways to the lungs. From here, nicotine passes directly through the alveolar epithelium into the bloodstream. Although nicotine can interact with a variety of receptors in numerous tissues, as we will see, it is its interaction with specific receptors in the brain that creates the dependence associated with smoking. Within seconds, nicotine is delivered to millions of neurons in the central nervous system. Here, within the midbrain, nicotine interacts with the alpha-4 beta-2 nicotinic acetylcholine receptors. Acetylcholine is the natural ligand for these receptors. However, nicotine, also an acetylcholine receptor agonist, has a higher affinity for the alpha-4 beta-2 receptors. Located on postsynaptic neurons, these receptors are comprised of 2 alpha-4 and 3 beta-2 subunits that form a channel for transporting ions through the membrane. When two molecules of nicotine or another ligand engage binding sites within the receptor, the ion channel is activated. Looking into the receptor, we see that it is closed, but activation by ligand triggers internal rods to open the channel for the passage of calcium, sodium, and potassium ions. This initiates electrical impulses, generating an action potential. This signal is rapidly transmitted down the axon to the reward area of the brain. Here, the impulses stimulate the release of neurotransmitters, including dopamine. Dopamine triggers additional signaling events that stimulate the reward circuit, generating short-lived feelings of well-being, improved mood, and increased attention. Every time tobacco is used, dopamine levels surge. However, nicotine is eliminated rather rapidly, causing dopamine levels to decline. The result, a craving for more nicotine. With continued tobacco use, alpha-4 beta-2 nicotinic receptors undergo complex adaptive changes, including upregulation and desensitization. Over time, these and other downstream changes contribute to a stronger need for nicotinic stimulation to achieve the rewards of smoking.
Great. Thank you, Tina, for sharing that video. So hopefully that also gives you a better understanding of the addictive nature of nicotine and the mechanism of action. So knowing all of this, sorry, Tina, can you hear me?
Yes, we can hear
Okay,
you.
sorry, thank you. So knowing everything that we've just talked about right now, hopefully we can all understand that we need to treat tobacco dependence for the medical problem that it is, right? It's not a social issue. This is a medical problem. It's an addiction. And we should all be providing that non-judgmental and patient-specific advice regarding the importance of smoking cessation. We know the health impact of tobacco use, in particular within the stroke population. And because of that, we have an ethical responsibility to advise our patients and to offer support. So, what do the guidelines tell us? Level A evidence here. So, the guidelines tell us that we need to identify and document patient tobacco use status, provide that non judgmental and specific advice, support a quit attempt, and manage nicotine withdrawal for tobacco users while admitted, and referring to resources in the community. So interestingly, the number one reason that I often hear from staff, when they cite as a barrier to quitting smoking, is patient motivation to quit. However, we know that the majority of tobacco users in Canada are motivated to quit smoking. This is a study just in our backyard at the University of Waterloo, and it showed that about 65% of Canadians have thought about quitting in the next 6 months, while 30% are ready to quit within the next 30 days. So in order to help these people become successful in their quit attempt, they need to be supported by their healthcare providers at every interaction. The evidence also tells us that patients expect to be asked and advised by their healthcare provider. And this is not healthcare provider specific. The recommendation is that all healthcare providers address tobacco use at every touch point in the system. But what about patients who tell us they're not ready to quit? Well, interestingly, studies have shown that people who are not ready to quit smoking quit at the same rate as those who are ready to quit. And this is why we no longer assess readiness to quit. So proactively offering tobacco users cessation-oriented treatment is beneficial for people who are ready and those who are not ready to quit. And if we don't do this, we miss out on treating a large population of patients who would benefit from our support. So how do we do this? What works? How do we support patients to make these quit attempts? The ideal support system here is a three-pronged approach: tobacco-free property, brief intervention, also called the 3As. We also call it minimal contact intervention, or MCI, and pharmacotherapy. So 3As in less than 3 minutes. It's very, very simple. So it's asking, advising, and offering a menu of options to support our patients. You do not need to be a tobacco cessation expert to do this. The key here is just to keep it simple. But does it work, right? So I'm encouraging you to do this, but what does the evidence say? Well, we know that minimal contact intervention is that simple 1 to 3 intervention that has a very high impact, low effort, high impact. If every healthcare professional spent 1 to 3 minutes at every visit with each patient implementing the 3As, the proportion of people who would smoke would decrease by 2% per year. And in the world of addictions, this is huge, right? And studies have also shown that advising and offering support to patients, so not just asking and advising, but also offering that support, can help to increase quit attempt rates by 40 to 60%. And this is huge. And I also want to mention here, abstinence from smoking, yes, that's our main goal. That's our end game here. However, it's an addiction. It's complex. People are going to relapse. That's part of the process. Any change in smoking behavior is considered a success. A quit attempt is a success. Decreasing the number of cigarettes smoked per day is a success. Not smoking in the car is a success, right? So, it does take people multiple attempts. But we do need to make sure, again, that we're advising, we're asking, we're advising, we're offering support at every visit, every touch point with the patient along the continuum. So what does this look like? It's very, very easy. You're asking the patient, have you used any form of tobacco in the past 30 days? Depending on your model, you might want to ask the last 6 months. Why do we ask 30 days? Because, patients may have been in Emerge yesterday, told they had a TA or a stroke, or they're admitted and they just quit yesterday. So, they may be a high chance of relapsing. So we want to ask, have you used any form of tobacco in the last 30 days? Then you're going to provide that very personalized, non-judgmental advice on the importance of tobacco cessation. And this is where I think providers get a little bit nervous, like, how do I approach this? What do I say? And my advice is have a standard script and stick to it. If you're doing this for after you get more comfortable, you can switch it up a little bit. But I've been doing this for a long time and I stick to my standard script. And that is the best advice I can give you is to quit smoking. It's going to significantly reduce your risk of having another stroke. If you're talking to patients who are admitted to hospital, you can also add in, while admitted, you won't be able to use tobacco the same way that you did when you were at home. So we're going to work together to manage your withdrawal symptoms while you're admitted. Again, very basic. It doesn't have to be complicated. And then there's the next step, which is ACT. And that is, what are we doing next for the patient? Are we providing written material? Are we providing a referral? Here in the stroke prevention clinic, we do have written material. We're very fortunate that we have a partnership with our public health unit. We can refer patients to them and they can receive 26 weeks of free nicotine replacement therapy. There are other programs out there, which I'll get into later. But if there is a referral process in your community, within your region, have that available, refer those patients out. The other piece around ACT is pharmacotherapy. So especially for patients who are admitted, they're going to get access to nicotine replacement therapy. In the outpatient setting, you may not have access to this, so you're not going to go down that path. Here in the stroke clinic, we're fortunate again, we work with public health, we're able to start patients on product while they're in the clinic, and then we refer out for ongoing treatment. So what does this look like in practice? This is a version of our tobacco use record that we used to use in our clinic. We now have electronic charting, so it looks a little bit different. Again, the key here is to have something very simple for nurses, therapists, social workers, whoever that you have working in your clinics. This is an outpatient record, but have something available that's easy, that's check boxes, that cues the clinician. You can even have in the advice section exactly what to say to the patient. We want to make it very, very simple for clinicians to implement the 3 A's. And if you're interested in what this might look like for your own clinic, you need some tips or examples, please reach out to me. I'm happy to help you. But again, the purpose of this presentation really is to hit home, like, what is our role in tobacco cessation? And it's so easy. It doesn't have to be complicated. Okay, here's one of our handouts, medications to help you quit smoking. This is a lengthy document that we give to patients. Again, if you'd like a copy, let me know. You may have some great handouts that you're giving out in your clinic or in the inpatient unit. I also have here an updated list of resources and places we can refer patients to in our region, and we keep this up to date. We give this to our patients. So again, if you're, let's say, in an area where you don't have access to free nicotine replacement therapy, you can give this to patients. They can contact Stop on the Net. They can get nicotine replacement therapy mailed to them. They can call the Ottawa Heart Smoking Cessation Program. They can get nicotine replacement therapy mailed to them from that program as well. There are a lot of supports available. Again, if you're interested in this, please reach out and I'm happy to email you a copy. Okay, it's time for our next check-in. So I'll let Tina pull up the poll.
It's up, Lisa.
Okay, great. So the first question is, nicotine inhaled from a cigarette reaches the brain in, is it 7 to 10 seconds, 30 seconds, 7 to 10 minutes, or 30 minutes? Okay, and the next question is a true or false. Individuals who are unwilling to quit at the same rate as those who are willing to quit. True or false? Okay, and then next question. Advising your patient to quit smoking and offering support has been shown to increase quit attempt rates by, is it 5 to 10%, 10 to 25, 25 to 40, or 40 to 60? And the last check-in question, who is responsible for addressing tobacco use? Is it doctors? Is it nurses, social workers, PT/OT, respiratory therapists, or is it all healthcare providers?
Okay, Lisa, we have lots of responses in for the first question, 93% of people have indicated 7 to 10 seconds.
Yeah, and that is the correct answer. Again, 7 to 10 seconds, and that's why cigarettes are so highly addictive, because the nicotine does reach their brain so quickly.
Okay. For number 2, individuals unwilling to quit at the same rate, 64% said true and 36% said false.
Yeah, so this is actually true. So people who are unwilling to quit at the same rate as those who are willing to quit. And this is why we don't assess readiness to quit. We implement the 3 A's, whether they're ready or not. We don't even ask if they're ready to quit. So again, you're asking, you're advising, and then you're acting. Okay, so we're going to help you with that quit attempt. We're going to, there's resources in the community where you can get support. Did you know you can get free nicotine replacement therapy? Right? So you're providing that support to people regardless of willingness to quit.
Okay. For number 3, 54% said 40 to 60% will increase the attempt rates when you offer support in addition to the advising, and 46% said 25 to 40. So almost a 50-50 split.
Yeah, and the answer here is 40 to 60%. So it's very powerful, right? So advising your patients and offering support increases quit rates by 40 to 60%. It's huge. It's huge.
Okay. And the last one, 100% of people said all healthcare providers.
Amazing. Great. Thanks, Tina. Okay, so the last portion of the presentation is going to focus on pharmacotherapy. Now, this presentation is really on minimal contact intervention. So again, if you're doing the 1 to 3 minute intervention, you don't need to delve into pharmacotherapy, but I wanted to present some of this information just as an FYI in case it does come up with your patients. And this is, again, just a really high level overview. We can get into quite a bit of depth with these products. So the one product that we really promote is nicotine replacement therapy, also called NRT. It comes in various forms. There's a sustained release long-acting patch, and there's the immediate release or short-acting. And that gives you, the short-acting products give you that hit of nicotine similar to a cigarette. So we have the gum, the lozenge, the inhaler, the spray, and the mist. Now, we know that using just the patch compared to quitting cold turkey, patients are actually 2 times more likely to quit if they use the patch versus cold turkey. Now, if you're using combination therapy, which is what we recommend, so the patch plus a fast-acting product, it's nearly 3 times more effective versus quitting cold turkey. So we're really, really big on promoting combination therapy. And then that combination therapy plus support in the form of counseling, 4 times more effective. Right. So one of the things we do in the stroke clinic here is that we do follow-up calls with our patients who use tobacco products, and we do a touch base with them. How are things going? What are you struggling with? And we do provide that support over the phone with our patients after their initial visit in the clinic. So delving in a little bit deeper with the products here, the transdermal patch, the nicotine's absorbed into the bloodstream through the skin. It's used for 24 hours. Some patients will say that they have trouble sleeping on the patch. We usually say give it about 2 or 3 nights. If you're still having issues, you can take it off a couple hours before bedtime, but it works better if they do have it on for 24 hours. You can apply it anywhere on the body where there's no hair, and we always recommend rotating the locations so that the skin doesn't become irritated. You can smoke while you have the patch on. Remember, you're just getting nicotine. Okay, so some patients will use the patch and then they'll use a strategy of reducing to quit, and that's totally okay. We don't want patients to take the patch off. So dosing of the patch, it's based on the amount of cigarettes the patient smokes. So it's about 1 milligrams of NRT per cigarette smoke, and you titrate it up and down based on cravings. One of the biggest problems we find, I think especially for inpatients as well, is they're not dosed appropriately. So if someone smokes 40 cigarettes a day, a 21 milligram patch is really not going to do it for them. So patients will often say, well, I tried the patch, it didn't work. And if you delve a little bit deeper, you're determined that they weren't really dosing themselves appropriately. So we need to make sure we're giving the patients the right dose of product and titrating it as needed. So they wear the patch and then they supplement it with the fast-acting products. Again, they can still smoke while using these products, right? Can they get too much nicotine? It's possible. Usually they might get some, they can get diarrhea, they can get headaches, dizziness. And then if that happens, they just peel back on how much they're using. In all the years I've been doing this, I've only had a few patients really experience those side effects. So the gum, the biggest point here with the gum is that it's not chewed like regular gum. It's a bite park method. So again, patients will say, I used the gum, it didn't work. So important to make sure they're using it correctly. If they chew it like regular gum, they'll swallow the nicotine. It's not dangerous, but there are some nicotine receptors in the gut and they will develop some nausea with it. The lozenge is similar to the gum, except you're not biting it. If you bite it, again, you're going to swallow the nicotine, get an upset stomach. So the strategy here is you're going to suck it twice, then park it between the cheek and the gum, keep it there for about a minute, and then move it over, suck it twice, park it. The inhaler, so it's called an inhaler, but you're not actually inhaling the nicotine. So there's a mouthpiece with a nicotine cartridge. There's really good instructions on how to use this product online. You use it as needed. And again, it's not inhaled, it's absorbed in the inner lining of the mouth. So we usually have patients in clinic demonstrate the use of this with us to make sure they're using it correctly. If they take too deep of an inhalation, they'll start coughing. It's not dangerous, but it's not going to work. So again, how to use these products, proper use is really, really, really important. The mist is another great product. One spray is one cigarette. It has a very strong sort of spicy mint flavor. The most common side effect I find with this is hiccups. And we find when patients are in clinic and they're using it, if they usually develop hiccups right away. And if they develop hiccups, unfortunately, they're probably always going to have hiccups using the mist. So again, we start patients on multiple products at once. Like we have patients come in, they're on the patch, they want the mist, they want the inhaler, they want the gum, that's fine. The key here is they're just getting nicotine. They use what they need. And the idea is to wean off the products. However, you can be on these products long term. Again, it's much safer than smoking. Nicotine is not dangerous, right? So again, idea is to wean off, but it's safe to use long term. This is a very busy slide. I just want to put this up here. So for any of those working in clinic who are doing smoking cessation counseling with their patients, this is something our nurses use to guide their telephone visits with patients, or for starting patients on nicotine in clinic. This again guides us with how to, just to make sure they're using the products properly. We have a lot of these sort of documentation forms and on hand. If you're interested in having this available to you, again, reach out to me. The idea here is to make it really easy for clinicians. Again, this is going way beyond minimal contact intervention. This is getting into a bit more in-depth cessation counseling. So if it's something you're interested in, please reach out. There are also oral medications to help people quit smoking that are very, very effective. Varenicline is an excellent one. It's a partial nicotine agonist. It blocks nicotine receptors. So I usually draw a picture for patients. I draw a circle for a brain. I draw the nicotine receptors, and I just tell them when they're using Champix, it kind of blocks that receptor, and you still get a partial release of dopamine. When patients smoke using Champix, they don't get that reward. They don't get that sort of good, relaxed feeling. It does triple the odds of quitting compared to placebo. So it's very comparable to combination therapy of NRT. The most common side effect with varenicline is nausea, upset stomach. So we always recommend people use it. They take it with food and a full glass of water. It is covered through ODB as well. Zyban is another medication that helps to reduce withdrawal symptoms, doubles the chances of quitting. It's contraindicated in patients who have a history of seizures or they're receiving current treatment with MAO inhibitors. The last thing I want to talk about here is cytazine. You may have heard of this. It's there's a lot more buzz going around about it. It's a natural health product that has that mimics the effects of nicotine. It's very effective with smoking cessation. It's available usually at natural health product stores. The dosing regimen is a bit complex. I haven't had any patients come to me using cytazine. We don't have a lot of guidance right now on how to use it. There's resources out of the Ottawa Heart Institute. So if you're interested, I can help connect you with that. I have reached out to our public health partners as well. They're not seeing a lot of patients using this as well, but I just wanted to plug it. You might see more patients using this in the future. Okay, so a quick check-in. I'll have Tina pull up the poll.
It's been launched, Lisa.
Okay, thank you. So the first question is combination therapy for nicotine replacement therapy in the form of patches and fast-acting products are 3 times more effective than quitting cold turkey. True or false? Okay, and the next question is people who use the nicotine replacement patch, and I could also throw in there also the short-acting products, should remove it when smoking cigarettes. True or false?
Okay, I think we've got most
Good.
people. 100% have chosen true for the combination therapy being
Yeah,
3 times.
that's correct. Wonderful. Thanks, Tina.
And for the second question, 82% chose false.
Right. So the answer is false. So we don't want patients removing the patch or stopping the fast acting products when they smoke. Again, it's just nicotine, right, which they're already getting from smoking. So we don't want them to remove the products. If you're counseling patients, doing a bit more in-depth counseling, if you're noticing patients are smoking quite a bit when using the products, we might need to bump up the dose. Again, you want to dose according to their cravings and what their needs are. So don't be afraid to bump up the dose and encourage higher usage of the products. And again, a lot of patients may use the products as a means to reduce to quit. So they're going to be smoking while using the products. Great. So just a quick talk about slips. If a patient slips and has a cigarette, again, slips are just part of the addiction, right? It's part of the quitting process. We want to reassure patients that quitting is not having a slip is not a failure. We don't want them to panic. I always tell patients, expect it might happen. It's not a big deal. Think about what might have contributed to it and move on. It's part of the process. We want to normalize slips. So remember, like we often say, perfect is the enemy of good, right? So patients don't need to be perfect on day one. They don't need to be 100% quit on their quit date. It's a process. Harm reduction is another thing I want to talk about as well. Very common, a concept that we encourage our patients to follow through with if that's the approach they want to take. It's really meeting people where they're at. It's a non-judgmental, non-coercive approach. It offers a way to get people engaged and increase their confidence so that we can help them move towards quitting. Although using less tobacco may have little to no effect on increasing survival rates, reduced consumption can definitely increase the likelihood of future cessation. So again, we want to meet people where they're at. And this, as I mentioned before, it could include things like cutting back, smoking half a cigarette, smoking outside, not smoking in their car, anything like that. So harm reduction is definitely a very positive approach. So a few things I just wanted to summarize based on the presentation today is we know that tobacco is the leading cause of preventable death in the developed world. The majority of people who smoke want to quit. Asking patients about smoking is not being intrusive, and research shows that asking, advising, and assisting increases quit rates substantially. We have an ethical responsibility to address tobacco use, and providing support to patients who are both ready and not ready to quit is essential because they both quit at the same rate. And the key here is keep it simple and keep the conversation positive. Let patients know that you believe they can do it. Okay, so that's the end of the presentation. Tina's going to get into the evaluation. If there's any questions, I'm happy to take them.